Thank you.
Thank you. Thank you so much, Tarun. Respected Vadirani sir, Bhagirath sir, and all the distinguished faculties here. Special thanks to Kamal bhai and the whole team of Cardicon for inviting us and keeping this a very interesting debate or debate, case-based debate for this particular August audience. So the case which has been given to me is 70-year-old male, diabetic, hypertensive, dyslipidemia. Each word is very important. Strong family history with past history of severe stroke 6 years back with a near complete recovery, post PTCA with multiple stents and having a history of inferior MI 1 year back, comes for the follow-up. Apart from medical optimization and lifestyle modification, therapeutic lifestyle modification, best strategies for risk reduction. So here the word is risk reduction, where this particular subset of patient can be put, and for that the role of rivaroxaban and aspirin is being given to me. Why is it so? Because this particular patient is falling into the category of chronic coronary syndrome. We all know about ACS, which is STEMI, non-STEMI or unstable angina. But chronic coronary syndrome is a conglomeration of multiple disease or a group of disease, which is starting from stable angina to new onset heart failure with stable CAD, stabilized symptoms in less than 1 year of post-ACS event. Here in our class or in our case, it is patient with more than 1 year after initial diagnosis or revascularization, vasospastic angina and asymptomatic CAD. All these 6 classes are considered as a chronic coronary syndrome patient on the basis of 2019 ESC guideline. Now the information which I want, apart from the information which has been provided to me, is what is the LV function on an echocardiography, what is the Doppler study, whether the multiple stents are there in the multiple vessels or multi-stents in a single vessel. What is the renal function? I need to be very careful when I'm choosing any strategy regarding the eGFR, history of smoking or tobacco in any form, and is there any presence of peripheral arterial disease, because patient is already having a CAD and cerebrovascular disease. So we need to find out whether the patient is having coexisting PAD or not. These are the information which are required, because my approach or anybody's approach should be more comprehensive and it should be patient centric. So when we are talking about this particular case, atherothrombosis. Now this is the word. It is not atherosclerosis. It is atherothrombosis, which is unpredictable and life-threatening consequences of chronic and progressive atherosclerosis. And here you can see that whenever the patient is having severe death, MI or stroke, altogether the incidences are increasing. It is crossing more than 8% a year. Now look at our patient. Our patient is 70-year-old male, atherosclerotic. Look at the history of cardiovascular disease. Yes, number 1. Number 2, history of MI. Yes. History of severe stroke. That is also there. And history of multiple stents. Now, just by this history, you can make one thing very sure, that whenever there is a presence of history of stroke or MI, the number of years or the longevity or the lifespan is getting reduced. You can see that it is 12 years lesser in a patient who is already having stroke. So we need to be very careful in choosing the molecule which has got a mortality benefit, which has got a survival benefit. And that is the reason whenever we are choosing any molecule, we always look for the 3 TMAs, that is severe death, MI and stroke. Here is the registry, which is a REACH registry, involving almost 65,000 patients, more than 45 years of age, and with a prior ischemic history of more than 1 year. Almost 20% of the patient, they are having an increased risk of severe death, MI and stroke at the end of 4 years. So is my patient falling into the category of COMPASS? Yes. COMPASS eligibility criteria requires the presence of prior MI, multiple vessel disease, multiple stents, age of the patient more than 65, additional risk factor like diabetes. We do not know whether the patient is having any history of current smoking or not, but if it is there, then yes, it is one of the major risk. If there is any presence of peripheral artery disease, that also requires to be added, and there is an already an established history of CV stroke which was happened before 6 years. So where does our patient stand? If I look at the guidelines, then 2019 European guideline or Canadian guideline and 2020 ACS guideline on non-ST elevation MI, both are saying that those patients who are having diffuse multivessel CAD, at least one of the following criteria, which includes diabetes, CV stroke, prior MI, technical aspects, multiple stents or multiple lesions, or if there is a presence of any stent failure in the previous history, that needs to be taken as a high ischemic risk category. Now here in our patients, we all know that this patient is at very high risk as far as the thrombotic risk is concerned or atherothrombosis is concerned. And because of that, we are always looking at the enrichment criteria. Now, which are these criteria? These are the criteria which are making the patient for making them eligible for the COMPASS category. Why is it important? Because whenever you have multiple risks or age more than 65, which is there in our case, number 1, diabetes, that is number 2, history of ischemic stroke, that is number 3. Say for example, if the patient is having LV dysfunction, then there is heart failure. So as you go on increasing the number of risk factor, the net clinical benefit is also going to get increased with the help of dual pathway inhibition. And that is what enrichment criteria means. And that is the reason this patient is definitely going to get benefited highly by giving dual pathway inhibition therapy. So DPI is a proven effective option as far as the European guideline concerned in a high ischemic risk chronic coronary syndrome patient. And here the recommendation is being given to aspirin along with the rivaroxaban in a vascular dose, that is 2.5 mg twice daily after 12 months of DAPT in a patient who has received ACS PCI or in this case infeasible MI having stent placement. After 12 months, you can always subject this patient to receive rivaroxaban 2.5 mg along with aspirin. And why is it so? Because in a chronic phase, you are not much dealing with the platelet activation, but you are more dealing with the prolonged thrombin generation. And that is the reason in a chronic phase, you require a drug which has got a dual pathway inhibition, which will help in significantly reducing severe death, stroke and MI. And here you can see that in COMPASS, there is a 24% relative risk reduction by giving rivaroxaban plus aspirin vis-a-vis rivaroxaban alone in a higher dose of 5 mg or aspirin. Extremely important point is in this slide. Why we are choosing rivaroxaban? Because it is the only drug which is not only having a reduction in the MACE, but it is having reduction in the all-cause mortality. Now let me know a number of drugs which are having all-cause mortality benefit. In cardiology, you have ARNI, you have SGLT2 inhibitor, you have beta blocker and statin. Apart from that, if you have any other molecule apart from this standard molecule is rivaroxaban, which has got a all-cause mortality benefit. On top of that, there is a reduction of the stroke. That is 42% reduction of the stroke, which has already been studied with an acceptable bleeding profile with DPI regimen. There is no evidence of fatal or intracranial bleeding which was low or similar in both the groups. So irrespective of the history of MI, whether it is less than 1 year or 10 years, irrespective of the history of PCI, whether it has been done or not, rivaroxaban aspirin combination is going to favor as compared to the placebo. Because stroke reduction, which is very important, it is the only molecule which has got a stroke reduction which is even better than any other dual antiplatelet or other P2 receptor inhibitor like clopidogrel, prasugrel or ticagrelor, which was being studied in Karishma trial, DAPT trial or Pegasus TB54, where none of the molecule has shown any significant reduction in the stroke, which is being there with DPI or a rivaroxaban. So net clinical benefit is being established with a reduction in the CV outcome or a CV events, which is significant. As the months passes, the benefit is getting increased with a very acceptable bleeding profile. Previous PCI or no PCI, whether the patient is having any history of MI or not, or prior MI which is more than 1 year, all these factors are getting a consistent reduction in the benefits of MACE events, which is not there with the thymic PCI. 2 minutes. So Pegasus, which was being compared against Compass, Pegasus is the trial of ticagrelor, where MACE reduction, modified major bleeding, which is not the case with rivaroxaban, and all-cause mortality. This is the differentiating point, which is 23% relative risk reduction, which is there in more than 24,000 patients in Compass arm as compared to Pegasus. If I am looking at Compass PCI and Thymis PCI trial, here also in Compass PCI, all-cause mortality and CV mortality are getting reduced with rivaroxaban as compared to ticagrelor. And that is the reason I think in my case, I would always choose rivaroxaban aspirin combination as compared to any of the other antiplatelet therapy, because of the fact that the patient is very high risk, patient is antithrombotic with an acceptable bleeding margin. I would always keep my patient on a drug which has already been proven, which has already been established in the guideline, and it is the only molecule which has got a significant reduction in the all-cause mortality with a modest reduction in the MI, stroke, severe death, and MACE with an acceptable bleeding profile. I would always choose DPI in this particular case. So just nutshell, CCI at high or a moderate ischemic risk and a low bleeding risk case, whether my patient is having previous MI, yes. If the year are less than 1 to 3 years, yes. Either rivaroxaban or ticagrelor, but if there is a previous history of stroke, then I would always choose DPI. In my case, I would always choose rivaroxaban. And in a multivessel disease or a multiple stent, then also I am going to use rivaroxaban. Thank you.
Dr. Vajirani Sahib and other friends. At the outset, I would like to thank Dr. Kamal and his organizing team for giving me this opportunity. And since we are facing this problem of the computer-assisted devices making a projection successful, since my days of early days, I am not a very computer knowledgeable person, but as a child, I have learned in the epic of Mahabharata, the curse the Karna had, that at the right time it will not work. So I remember that the computer science is like that. At the right time, it can create some problem for us. So here I am supposed to deal with is the ticagrelor 60 milligram is preferred antiplatelet for the long-term use in this patient. You see, we have a patient profile. He is a 70-year-old man, diabetic, hypertensive, dyslipidemic, history of severe stroke 6 years back, and before 1 year, he had underwent PCI with 3 stents. I assume that it must be a drug-eluting stents. And now, what is the role of secondary prevention for these patients? We need to have, as Dr. Jay has also highlighted, some inputs from the history, whether it's what is the CKD status or EGFR, ongoing medication post PTCA, does he have a PAD, the type of the stroke and the ejection fraction. But pertinent to that, is there any need for a long-term ischemic protection in this patient? That is the first question need to be asked, and what is an evidence or what the literature says about this? You see, there are a lot of data. One of the slides which I have selected from the REACH registry, it says that the patients with a history of ischemic event are twice the risk of MACE for up to 48 months. That nearly 4-year data. That if from a normal population, which will have with these background of multiple risk factors, at the end of 48 months or 4 years, the cumulative incidence of the MACE will be about, say, 9%. But our patients is likely to have an incidence of about 18.3%. So nearly twice. So there is a definite need that the ischemic events are likely to happen, and we need to reduce it. Similarly, in Apollo 1 registry, 1 in 5 patients who were event-free for the first year following an MI develop a subsequent MI, stroke or death within next 3 years. So whether it is a population sample was taken from different country, it doesn't matter. In all these populations, of course, Indian populations was not covered in this data, but they all showed definitely increased MACE rate following a first ischemic event in form of an acute coronary syndrome. And in one of the trial, the MACE was 15% at the end of 6 years after the MI. So consistently it shows that after a first acute coronary event, for a couple of years, there is a likelihood of an increased ischemic event in these kind of patients. Now, if the patients have got diabetes or a multivessel disease, they are still at a sustained or a higher risk in the subsequent years. Like say, if you have a non-diabetic patient and no multivessel disease, here that data is missing, whether the stents, all three stents were put in one vessel or whether it is a multivessel disease, but he is diabetic. So diabetics have much higher risk if you take particularly this example. Now, complex PCI, if you have performed, obviously these three stents, but it's a complex PCI. The secondary events for next 30 months are also definitely high. They are also posing a higher risk of stent thrombosis. So we need to have an agent which is likely to reduce the incidence of the stent thrombosis in subsequent years. So what is an evidence for long-term use of DAPT after this patient? That is nearly 1 year back he had an MI. You see, DAPT study to reduce the long-term risk of ischemic event was continued beyond 12 months. 12 months, there is an agreement, and all the guidelines say that following a PCI, we should give dual antiplatelet agents for 12 months, but this study was extended for another 18 months. And what was revealed was that if you continue this dual antiplatelet therapy, then you will have a further reduction in the composite of the death, MI or stroke at the end of the 30 minutes. So there are a lot of evidences. The Pegasus TIMI 54 study, which was comparing the ticagrelor 90 milligram twice a day with aspirin, which is a usual dose, ticagrelor 60 milligram BID with aspirin against only the aspirin after 1 year completion post intervention. And again, the primary endpoint was composite of cardiovascular death, MI or stroke, and the safety endpoint was TIMI defined major bleeding. And what did it show? That it shows a 16% relative risk reduction compared to aspirin alone if you are giving ticagrelor 60 BD with aspirin. But it is not, so whether it was a primary endpoint or whether there was a secondary endpoint, you found that the ticagrelor was definitely better than aspirin alone if you continued beyond the 12 months duration of DAPT. You see, this was achieved not at any major bleeding. Definitely the bleeding was higher when you continued dual antiplatelet agents, but the fatal bleeding or intracranial hemorrhage was no more in the ticagrelor arm compared to the placebo. So you are not going to increase the risk of bleeding complications in terms of mortality by continuing the dual antiplatelet agents beyond 1 year. And the benefit of the ischemic risk reduction clearly outweighs the risk of major bleeding when this was continued within 2 years, because in the Pegasus trial, the patients were enrolled even if they have a history of MI within 2 years at the time of inclusion. It also shows the net clinical benefit. If you take the irreversible arm, the cardiovascular death, MI, stroke, intracranial hemorrhage, and fatal bleeding all together, there was a 14% reduction. So put together the ischemic event versus the risk of the major bleeding or the fatal bleeding were reduced by 14% in this trial by continuing the ticagrelor 60 milligram twice a day. And what the recent guideline says about the use of DAPT therapy in patients with ACS who have undergone PCI, because our patient has undergone PCI with 3 stents, and whether it's a drug-eluting stent or whether it's a bare metal stent, and if the patient has no high bleeding risk. I will come later what is being defined as a high bleeding risk. If the patient has undergone the stenting and he is not having a high bleeding risk, they recommend in the green bar that you can continue beyond 12 months. The use of ticagrelor is preferred beyond 12 months for reduction of the MACE. And even the ACC or AHA guideline also says that beyond 12 months, one can continue the dual antiplatelet therapy in this subset. In our case, patient had a history of CVA, so the question of giving a prasugrel doesn't arise. Now, patient selection algorithm in this Pegasus trial from which these recommendations were generated, that patients who have more than 2 risk factors. Now, in our case, obviously there were more risk factors. Patient has hypertension, patient has diabetes, patient has dyslipidemia, strong family history, and these are the list of the multiple risk factors. If the patient has got a multiple risk factors, then the benefits is going to be more even in this subgroup of patients. So putting them together is going to get you the larger benefit. And this was not at the high bleeding complications or a fatal bleeding. Now, how will you define if the patient has a prior history of bleeding anywhere, or the patient has low hemoglobin? You may exclude after 1 year. And if patient has got a multiple risk, in absence of a high bleeding risk category, then you may consider these patients for continuation of the DAPT beyond 1 year. And then you are likely to achieve further benefits in these kind of patients. And cardiovascular deaths and all-cause death in low bleeding risk patients as per the number of the ischemic risk factor. If you have more ischemic risk factor, more than 2, in our case it was more than 2, then you are likely to have both nearly 34% relative risk reduction in cardiovascular death and 24% relative risk reduction in all-cause death if you have more than risk factor. Our patients have more than 3 risk factors. So we are likely to have the benefit of giving a ticagrelor twice a day in this particular category of patients, which is again highlighted in this slide. And there was a comparison with which the rivaroxaban has come in the use, but the 2 subset, I think, inclusion criteria, if you go to the COMPASS, the majority of the patients have MI 7 year or more. Here our patient has the MI just 1 year back, and patient received 3 drug-eluting stents. The status of whether the stenting was done or not is not clear in the COMPASS trial. So extrapolating the results of COMPASS trial for our given patients, I think is not acceptable. And one more point, when you have a patient who have more than 3 stents, you have 3 stents, the chance of stent thrombosis are going to be much more. So I do not have an information, does rivaroxaban use reduces the incidence of the stent thrombosis after 1 year. But we have ample data by continuing the DAPT therapy, the incidence of the stent thrombosis can be definitely reduced. And there was also little concern about the statistical analysis which has been put forward in the COMPASS trial, because the subset which was selected for the COMPASS trial is not identical with the patients which is in question. So the COMPASS trial results cannot be extended word to word for this category of patients who is just had a 3 stents 1 year back and has a multiple risk factor. Thank you for your attention.